Well, I have to admit something. This case is not my best save of the year. This case is one of my saves from when I was a novice interventional cardiologist. And I chose that case on purpose because throughout this meeting yesterday and today, there's been awesome cases and awesome complications saved. This is definitely nothing like that. This is more for, I thought, target people who are novice, who may have a complication that they need to work on. And a lot of things that I did then, I would definitely not do now. So it'll be hopefully a good discussion. So this is a 60-year-old female presented to the ER with anterior STEMI. This is the EKG. She has HIV on heart. Interesting enough, she was having some chest pain, which we thought was cardiac in nature. But she had a stress test and she went 8.2 meds, achieving 89% maximum predicted heart rate with no ischemic changes on the EKG, and the imaging was completely normal. So we treated her medically, did not do an angiogram at the time. This was a few months before her STEMI. And other comorbidities like you can see there. So this is her angiogram when she came to the cath lab. I also go up with the guide first when it's an anterior STEMI especially. So you see severe stroke disease, the LAD is completely gone, ostial occlusion with a small ramus there. So the plan was to proceed with, of course, intervention on the LAD. She was on a given heparin, and we tried to cross that LAD a lot with many wires. I didn't even name all of them. But first, the wires kept slipping into the obtuse marginal. We put a 1.5 balloon in the obtuse marginal, occluded the obtuse marginal, kept trying to get any wire down the LAD. We just could not wire it for whatever reason. We tried even to get some support. We couldn't with a supercross. Then finally, with a 45 angle supercross, I said I'm going to poke it with a Confianza Pro 12, which I have to say I did not have a lot of, at the time, experience with the Confianza Pro 12. So as a fellow, you do some cases and you think you know what you're doing. When you become a novice attending, that was almost 10 years ago, really you don't know what this wire can do. So here's my balloon occluding the intermediate ramus because we really could just not keep slipping into it. The 45 angled support catheter and the Confianza trying to go in the LAD. And the Confianza goes, and you can see, trying to make sure it's straight, but the way it's going does not look like it's going in a vessel. It's just too straight to be a vessel, to be honest with you. And of course, now you have this perforation, and definitely the Confianza somewhere either in the lungs or in the pericardium. God knows where it is at this point. But, took it out, and here's what we have. It's not, I can tell you, based on some of the perforations I saw yesterday, this is nothing, right? Yeah, but now this is a patient with STEMI. You're working against the clock. You have a perforation, fully anticoagulated on heparin. What to do next? I think the steps to do next would be the things not to do, and I knew even at the time I should not do that, is inflate a balloon in the left main to occlude this perforation, because then the patient's definitely dead. This is probably, the only thing I cannot do. But we thought maybe we'll rewire the OM and try to put a balloon in the OM, and we were lucky, I would say, that the balloon inflation in the OM completely sealed that perforation. Waited the first 5 minutes, took a picture, there was still perforation. So I was like, again, thinking at the time, which I probably would not have done now, let's reverse the heparin. I just want to get this perforation sealed. She's having STEMI, called my cardiothoracic surgeon, try and get him back up if needed. After reversing the heparin, we were able to seal the perforation. During that time, when we had the balloon up, I got the contralateral access, and I got just a picture on the other side, because sometimes if the perforation is somewhere where you think you sealed it from the, from the ramus, maybe it's still also the Confianza was somewhere, I don't know where, maybe it had another perforation. So we just wanted to make sure there was nothing seeping. There was nothing, and now we were back to where we were. So continued to have chest pain, persistent ST elevations, this is not doing good. Hemodynamically stable, and she had already received protamine. So after all this was done, the perforation was sealed, we still needed to fix this. The surgeon said we cannot take her to the cath, for whatever reason, just didn't want to take her to the OR. So I thought, okay, I'll change my strategy a little bit. Instead of using a 45 angle, catheter, I'll use a 90-degree catheter, and if I put my wire there, it won't go exactly where the perforation was. Maybe it'll go on a different plane. And don't ask me why I used the CrossFit 100 XT wire. Probably that was the only wire we have in the cath lab that I had not tried at the time. But I guess we were lucky enough, we were able to get into that LED. The wires going in a diagonal, as you can see, did not follow the same perforation before. And after that, we just balloon angioplasty, did a stent, and we were able to save the LED. But to give, because she was already given protamine, I gave Angiomax at the time after I crossed into the LED. So the reason was, I mean, she's on protamine, I cannot give her more heparin, I don't know what the anticoagulation is going to be. And I chose Angiomax because I knew I wasn't the true lumen at that time. And if I needed to do a covered stent or whatever, I can. Thankfully, the reversal of heparin did not hurt us a lot. Usually, if you reverse heparin, you have to do balloon inflation in the main vessel. You can have thrombosis. Sometimes the clot in the pericardium can clot. You cannot aspirate it if you need to. In this case, we had the left main open into the circ. We didn't affect that flow. So I felt comfortable giving Angiomax. Whether this was the right thing or not, it worked. But this is the case.
Perfect.
All right, thank you.
I actually think that's a great save. I think a great save 10 years ago would be a great save today. Because as you just presented, there were really very limited options. And I think it's one of those situations where first maybe a surgical opinion. I'm curious, Ashish, do you find it's easy, or have you ever been able to convince the surgeons to operate in this kind of situation? Or is it even appropriate?
No, so
to be.
So I'm giving you my historical perspective. I used to call them, and then I got so tired of them saying no that now I don't call them, because the answer is always no. And so I think you end up with a situation where now hopefully we don't need them as often, thankfully.
Should you call him just for documentation? I mean,
I
they
don't
just said
think
no.
so.
I mean, it's endorsing you for whatever you want to do. I mean, they already said no, so.
So you mean call them as an uncrossable lesion in this for an acute STEMI, or call them at the time of the perforation?
No, at the time of the perforation. Uncrossable lesion, I mean, you can still cross, and then if you cannot cross it, then the patient needs something.
I don't think we should give the message not to call the surgeons. And I think this is a huge STEMI in a young person with beautiful targets. And I totally agree that stars have to be aligned for everything to go. But the surgeons, depending on your institution and the surgeon, I think they will take it.
I agree. We take their opinion.
Which is my point, that it's an institutional dependent situation, and in my institution.
I mean, that's partly why I'm asking, because I think we have a similar struggle to try to get somebody to go emergently to the operating room, and for good reason. I'm not. If I put myself in the shoes of the surgeon, not uncommonly you get this call when it's a complete bomb, and so I'm not sure what I'm going to do. So we definitely work together as a team. But one of the things I noticed Manos in his algorithm, that was step 4, and I wanted to kind of bring that up to him. I'm not sure it's step 4 in my mind when I'm in the middle of a perf, because immediately you want to take steps that you can take. Because even if you call the surgeons, and even if they're willing to come and take the patient to the OR, you've got at least 30 to 45 minutes. So you've got to have those first 4 to 5 steps down pat that you have to manage yourself. I think institutionally it's very important to make sure that you have a good relationship with the cardiac surgery team, which I think this whole heart team concept has really brought to the forefront. But you need to figure out whether at your institution that's a viable option or not. Because if it's not, then that sometimes is it ends up being an extra 2 to 4 minutes, I find, in the middle of where my concentration is actually diverted.
I think the lesson and the teaching point of this case, more than anything else, is managing a penetration wire.
Yeah.
And I think that the fluorosafe image of the Comprehensive Pro 12 that you showed, and I applaud you for showing that, because that's a fabulous teaching tool for everybody in this room, is that you don't advance it the 4 centimeters that you did on that fluorosafe image. When you enter the proximal cap, assuming this is a CTO, and we're treating this like an ATO, whatever you want to call it, it's a lesion that you couldn't cross, and you do have to use a penetration wire. The thing to do is you advance it literally 1 or 2 millimeters. Switch views, choose 3 orthogonal views, confirm that you're tracking the direction of the LED, take your Confianza Pro out, switch to a polymer jacketed, low gram force wire. If it tracks in the lumen, you're great. If it doesn't track, you can always knuckle it, which is way safer. Get into the vessel wall, and you have tools to re-enter in 2016 in the mid-LED and save the day.
Absolutely.
Lot safer. Even the second try with the second penetration wire is something that is highly not recommended.
Was there a reason the surgical team declined this patient? I'm particularly concerned in the setting of a perforation where you could develop tamponade that's really a mechanical problem.
Well, even when they saw her and were actually in the cath lab with me, that we had, by the time they drove, it was in the middle of the night, by the time they drove from home and stuff, we had sealed the perforation. Maybe because it was in the course of an anterior STEMI with the cervical cancer and all this. I mean, I don't know, but I mean, you would think we got a picture from the right and the LEDs there. Lima to the LED would have been a maybe not very invasive surgery. I know it's in the setting of a STEMI, but anyway.
So circling back, we still feel like surgery has a very important role in this setting because you can manage the tamponade, you can put an emergency bypass graft on the LAD. Whether or not that's a Lima, that's a issue.
Or SVG,
but you could certainly do that.
But I think the challenge in what you brought up is what you can't do is get distracted for 10, 15, 20 minutes, step out of the cath lab while the case is deteriorating because you didn't really understand the time course of the effusion, whether you were going to have impending tamponade. Now you're trying to open the vessel while doing an emergent pericardiocentesis. So I guess the other thing too is that I'm pretty quick to put in contralateral access if the thing, most STEMIs don't behave like this, so you need to be thinking, what else is going on here and, are we missing something? And I think your contralateral injections were incredibly helpful and probably would have helped you earlier in the case before you got a perforation with if you think about the STEMIs, you've had to pull out a super stiff wire to cross. It's would be one hand. So I think before you launch into that, I think seeing where you were poking, looking at the robustness of the collaterals, whether they were or weren't present, because they really shouldn't be incredibly present. Those were great collaterals, and they would have helped you, I think, early on. So.
And plus, I think you very thoughtfully did do it for the right reason, because you're right. You don't know where the wire is exited, and it could have exited at multiple spots, and there could have been an ongoing perf in the LAD that you rightly chose to look at. So that was a good decision.
So are there tricks here? You could tamponade the vessel just by keeping your balloon in the ramus. But if you had to include the left main, are there tricks to keep the perfusion?
I'm happy I didn't have to. I think at that point I would have put a covered stent maybe there and called the surgeons. I don't know, how would you occlude the left main? This patient would definitely would die. I'd love to hear your opinions about that. I don't know.
With a much higher level of LV support than you were. If you were in trouble with the LAD occluded, I suspect you would have been much more trouble with it.
And then you stopped the circ. Even though the circ was,
the
RCA was a huge vessel.
You could have put a covered stent in the left main into the circumflex, and then used your surgeons as a backup in terms of bypassing that if you couldn't get that.
That's the only thing I could think of, really.
A guideliner in the vessel and put a balloon beside it.
Yeah, theoretically that makes sense. And in fact, we used to have these perfusion balloons where that would cover, a large area, but still you'd be able to perfuse the distal vessel. But yeah, actually that's a nice consideration. So get a guideliner into the circ and then another balloon right at the ostrum of the LAD to cover the perforation. But I think the other point is this is a wire perf, and most of those are fairly well tolerated. And as long as you haven't inflated a large balloon at that site,
this was free flowing though. This was.
I did see the.
This was really. At least it looked like it was wide open. It wasn't like the one we saw yesterday, but it was wide open.
One question in the back here.
This is just something we don't think about too often, but this would have been a nice case to have an ultrasound in your left main before you got more aggressive. Because you could have said, somehow, I'm trying to picture where you were. Clearly, it was sort of a blind stick in a sense.
Yes, sir, it was.
Should be, but it would have been so nice to have that little
IVUS and see where to go.
Aim for, and then you could be maybe a little bit more aggressive before you just start poking.
Absolutely
Super.
agree.
Great, that's a fantastic
Thank you.
case. Thanks,
Thank
Mazen.
you.